Now let's look at what thrombotic microangiopathy actually looks like on kidney biopsy and how immunofluorescence helps confirm the diagnosis. Biopsy finding in TME can be broadly divided into acute lesions and chronic lesions. Starting with the acute changes, one of the key features is intraluminal fibrin-rich thrombi, partially or completely occluding small vessels. We often see endothelial swelling, reflecting a direct endothelial injury. Within the capillaries, red blood cells becomes fragmented as they pass through these microthrombi, which mirrors the schistocytes we see on the peripheral smears. Mesangiolisis may be present, sometimes accompanied by microaneurysm formation, and the intramural fibrin deposition within arterioles. Now moving to the chronic changes. Here, the biopsy reflects ongoing or prior vascular injury. We see double contour formation along the peripheral capillary walls, hyaline deposits within arterioles, and progressive intimal thickening with concentric lamination. Now let's focus on the immunofluorescence image on the right. What stands out here is strong fibrinogen staining within the vascular structures, particularly the arterioles. This bright linear staining pattern represents fibrin-related material, highlighting active endothelial injury and thrombus formation. Importantly, this is not immune complex deposition. The staining localizes to vessel walls and lumens rather than showing a granular glomerular pattern, which supported the diagnosis of thrombotic microangiopathy rather than immune complex-mediated disease. In TMA, immunofluorescence is often negative for immunoglobulins and complements, but fibrinogen staining can be striking. So even when light microscopy findings are subtle, and even when schistocytes are absent in the blood, immunofluorescence can provide a decisive clue that this injury is vascular and thrombotic in nature. Let's walk through these images together, starting with the images on left side. Here at the glomerular level, you can see fibrin-rich thrombi located at the vascular pool and within the capillary lumen. On routine H&E staining, this fibrin appears as pink amorphous material, and on silver stains shows up as non-argiophilic material, confirming that this is fibrin, not basement membrane material. These deposits physically obstruct the capillary flow and represents one of the earliest lesions of acute thrombotic microangiopathy. Now shift your attention to the image on the right side. Here the arrows highlights glomerular capillary occlusion by fibrin material. You also notice areas of mesangiolisis where the normal mesangial matrix is dissolving, and the mesangial cells appear fragmented or even lost. In some regions, this structural breakdown progresses to microaneurysm formation, reflecting severe glomerular injury. These right-sided images show how microvascular thrombosis directly damage glomerular architecture. Now move your eyes to the image at the bottom. This is a vascular compartment. Here you can see fragmented red blood cells trapped within the vessel wall. The tissue level correlates of schistocytes seen in the peripheral smear. The arterioles show marked endothelial swelling, leading to luminal narrowing or complete occlusion. In the more severe examples, there is fibrin deposition within the arteriolar wall itself, sometimes accompanied by fibrinoid necrosis. This bottom image captures active and ongoing vascular injury and explains the abrupt decline in kidney function seen in acute TMA cases. So when you put all of these together, the left image have fibrin thrombi formation, and the right image have glomerular structural breakdown, and the bottom image have arteriolar injury and red cell fragmentations. This is acute thrombotic microangiopathy on biopsy driven by endothelial injury, platelet-rich thrombosis, and mechanical hemolysis. Now let's move to the chronic changes of thrombotic microangiopathy. Start with the image on the top left. Here you are looking at arterioles with marked concentric intimal thickening, what we often describe as onion scanning. The vessel wall is progressively thickened by layers of fibrosis, leading to severe luminal narrowing. This reflects repeated or ongoing endothelial injury over time, not an acute event. Now shift your attention to the image on the top right. At the glomerular level, you can see features of chronic ischemic changes, like damage. There is segmental sclerosis with areas of capsular adhesions, highlighted on trichrome stain. You will also notice cellular interposition within the capillary walls. A response to chronic endothelial injury and subendothelial expansion. These findings explain why chronic TME often present as slowly progressive graft dysfunction, rather than an abrupt decline. Now move your eyes to the image at the bottom. There highlights chronic glomerular ischemic changes. On silver stain, the glomerular tuft appears relented and collapsed, a classic ischemic pattern. And on H&A, you can see a relative bloodless glomerulus with mesangial collapse. And most importantly, on higher magnification silver stain, you'll see double contour formation along the capillary walls. These duplicated basement membranes are the histologic footprint of chronic endothelial injury and repair. So when you put all of these together, the top of left shows chronic arteriolar remodeling, and top right shows chronic glomerular scarring, and the bottom image shows ischemia and basement membrane duplication. This is chronic thrombotic microangiopathy on biopsy, a record of past vascular injury, often irreversible and closely linked to long-term graft dysfunction.